Hello everyone, welcome to my presentation of the 9 months progress report. I'm going to talk about uses of CT imaging in acute pancreatitis severity prediction and diagnosis of splanchnic vein thrombosis. So my name is Borbély Ruben. I'm a radiologist at Bajcsy-Zsilinszky Hospital in Budapest, and I'm a PhD student at CTM. My vision is to advance the understanding and treatment of acute pancreatitis. And to do this, the mission is to enhance the diagnostic and prognostic value of CT imaging. These two are my active projects that I'm going to talk about. The first one relates to splanchnic vein thrombosis prevalence in acute pancreatitis, and the second one focuses on body composition and the acute pancreatitis. So, about the first project, which is titled Time Dependency and Risk Factors of SVT Development in Early Phase of Acute Pancreatitis. SVT is a thrombotic state of the veins of the GI system, and it can be a local complication of acute pancreatitis. It affects around 5 to 26% of patients, but there is no data about the development dynamics and the exact prevalence in the early phase. So our question was, what is the prevalence of SVT in the early phase of acute pancreatitis? And to examine this, we have employed the COCO-POP framework. We have looked at SVT prevalence in studies that look at AP patients hospitalized, and there was some imaging done in the early phase. Through a systematic search, we have identified 10 studies and 5 additional ones through citation chasing. So here are the results of the analysis. The pooled proportion of SVT in the early phase, meaning that 12 days within symptom onset, was 0.13. The 0.13 is a proportion of 1, so it means 13%, or about 1 in 8 patients are affected. We have found that heterogeneity was quite high. To account for this, we have done further analyses to explore the causes. On these forest plots, you can see a subgroup analysis by diagnosis timing. And the interesting thing is that in the 0 to 3 days group, since symptom onset, the prevalence is quite low at 6%, and at 3 to 11 days, this rises to 23%. And on the right, you can see that on hospital admission, the prevalence is 12%, while 1 to 5 days after hospital admission is 17%. So these results suggest that SVT development takes place at least 3 days after symptoms onset. Additionally, the prevalence is high on hospital admission. On this third forest plot, you can see a subgroup analysis by disease severity. And you can see that increasing severity corresponds to increased SVT prevalence. In mild patients, we found 15%. In moderate and severe patients, 26 and 27%. But these results were not statistically significant, suggesting that severity is not the main risk factor in SVT development. On the fourth forest plot, you can see a subgroup analysis by disease etiology. And you can see that alcoholic-induced AP patients are the most impacted. The prevalence is 31%, or 1 in 3 patients has thrombosis. And in contrast, biliary patients have only a 12% prevalence. These results are both statistically significant and clinically meaningful, as they highlight high-risk patients. On this fifth and last forest plot, you can see a subgroup analysis by the amount of pancreatic necrosis, and the subgroups are that there is no pancreatic necrosis, we have found an 11% SVT prevalence. Necrosis under 30%, we have found that a quarter of patients are affected. And in the last group, with necrosis above 30%, we have found that half of patients have SVT. This is also a statistically and clinically meaningful association, as these patients are at a higher risk. Our analysis had strengths and limitations, and first strength would be that this was the first meta-analysis focusing on the developmental dynamics and the early phase of AP. We have a transparent methodology with prospective registration of the protocol in the Prospero database. And for the high heterogeneity that we have encountered, we have done multiple subgroup analyses, and that's to counter this heterogeneity. The limitations are that approximately 50% of our studies, the included studies, were retrospective by design, and most studies had low patient numbers, leading to some imprecision. So the conclusion is the following: SVT is prevalent in the early phase of AP, affecting around 1 in 8 patients. And this SVT prevalence is low during the initial 3 days after symptom onset, but rises subsequently. Alcoholic etiology and pancreatic necrosis are associated with an increased incidence of SVT, and they constitute a high-risk patient population. Implication for practice is that anticoagulation and screening especially should target these high-risk patients. Implications for research is that can SVT be prevented, or does routine anticoagulation benefit these high-risk patients? This slide summarizes the progress. We are at the manuscript writing phase. We have completed the other steps. The goal is to finish the supplementary material by the end of this week, and we hope to submit the article in the next month. A couple of words about the second project, where we investigate the effect of CT-calculated body composition on the outcomes of patients with AP. We know that overweightness affects many people. It is estimated that in 12 years, majority of the global population will be overweight. BMI correlates with severity in many diseases, including AP. But recent data suggests that body composition, and especially body fat and low muscle mass, shows a stronger correlation with a worse outcome than just BMI. Additionally, to calculate body composition, CT and MRI is the gold standard, and BMI is just an approximation. So our aim is, in this project, to understand the relationship between the CT calculated body composition and AP severity. So the question is there a significant association between these metrics and complications and severity and outcome of AP? And we will employ a PFO framework. We will look at the GULASH study participants that have a CT scan. We will examine them retrospectively and look for the CT calculated body composition and link them to outcomes. And hypothesis is that high obesity is associated with a worse outcome. Currently, there are around 500 patients in the trial who have a CT scan on admission and on discharge. They have received imaging with uniform imaging protocols, and we have downloaded these files, we collected them, and the next step is to calculate the metrics based on these scans. So to summarize, these are my active projects, and we would like to submit the first one by next month, and the second one in the fall of this year. I will end the presentation with a quote from Nelson Mandela: "It always seems impossible until it's done." And thank you for the attention.
I just have a question regarding your first plot. Do you have any idea why the difference was so big between the first proportion and the first article and the last article, between the proportions? Thank you.
On the overall proportion?
Yes.
Most likely the secondary factors come into play, as some studies report from the first day of symptom onset. It's probably those studies will report a lower prevalence, and some report up until the 12th day between symptom onset, and we expect to find a higher proportion on those studies. So that's why we have done the subgroup analysis. So the difference in part can be explained by these factors. Even the composition of the studies regarding the patient population was not the same, as some studies used more data from severe patients, and some studies included more mild patients. So that is also a factor that we have to take into account.
I have two questions regarding your second topic. I would like to know if it's within the scope of your project to propose cutoff values for adiposities, since you are extracting them from the sample that you're evaluating. And the second question would be, what would you do with this information at the hospital, for example, at the clinical setting, and how this could be useful?
Mm-hmm. Thank you for the questions. So regarding your first question, I would say that we wouldn't propose normal values, as there are some studies that have done that before us. So we would most likely base our methodology on them. And regarding your second question, it will be useful to get this analysis done on every patient who has a CT scan, as this data is already out there. So we could just use that data that is unused currently, and it would provide a feedback for the patients and the clinicians too, as low muscle content, for example, could signal that the patient is at high risk for death or a worse outcome in probably every aspect of life. And we could target these high-risk patients. And this to extract this information is not that hard, but currently not in protocol.
I have a question regarding your first project. You mentioned that there is a higher proportion for SVT in case of alcoholic etiology pancreatitis and compared with biliary. And what is your opinion about it? What is the reason behind it?
Mm-hmm. So one thing is that these patients have more severe disease that could contribute. The other thing is that alcohol consumption in high doses leads to a prothrombotic state, and it has been demonstrated to cause many types of thrombosis, including deep vein thrombosis. The amount of alcohol necessary to induce an episode of acute pancreatitis probably elevates the patient's risk at the thrombosis also, and that could be one.
Thank you very much.